Thank you. Thank you again, and I hope the course is doing fine. Actually, this switch in the program allows me not to be in the position of being in between a room full of people and their lunch. So you still are probably rested from the coffee break. The title of my talk is Patient-Ventilator Interaction, which is a rather broad topic, and I will focus mainly on two aspects, as you will see, and I hope it will be rather exhaustive. These are our institutional conflicts of interest, and I would like to mention that part of the data that I will show you today were supported by some ventilator companies. So when we speak about patient-ventilator interaction, what do we speak about? For the sake of clarity, I hope I divided this talk into two main chapters. One is the amount of assistance that the ventilator is providing versus the amount of work that the patient is generating. So this is the first aspect. How much are we supporting our patient? How much are we allowing him to do his own work or her own work? And the second one, so the first topic has more to do with the amount of pressure. And the second part of my talk, a bit larger, will be about the timing, the synchrony between the inspiratory time of the patient and the inspiratory time of the ventilator, and also of the expiration of the two, so that the two times are synchronized. So let's start with the first one. We do know that our patient has a given target in his mind. He or she wants to likely control the PCO2 and have it as a given level. So basically, the patient would like to have the minute ventilation to be constant. And we are able, with assisted ventilatory modes, to share the work of breathing which is necessary to achieve this minute ventilation in a variable way between the patient and the ventilator. So if we start from a patient who is on CPAP, which is also called the pressure support of 0, the patient has to perform the entire negative pressure swing which is necessary to achieve a given tidal volume. As soon as we increase pressure support to 10 or 20, what we will see is that the patient decreases the effort because the ventilator is delivering more pressure, and so the tidal volume is produced also by the pressure which the ventilator is delivering. So basically, the idea is that the pressure, the sum of the pressure that the ventilator and the patient are generating is constant, but by rotating the knobs on the ventilator, we can decide which should be the trade-off between the patient and the ventilator. In this case, what you see is that basically, no matter what the level of assistance is, the tidal volume remains constant, respiratory rate remains constant, because, as I said, the sum of the pressure generated by the ventilator and the patient is more or less the same. Practically, this is not what we see in most of the cases. You see, this is a study we published on anesthesiology a few years ago that had to do with another topic, but usually, in most cases, what you see is that as soon as you decrease the level of assistance, for the patient, it's easier to breathe at a higher respiratory rate and a lower volume, so that he or she has to generate a lower amount of pressure, and it's easier to breathe. And we see, I will just briefly allude to this because yesterday Antonio Pesenti spoke a lot about PO1, and we also see that as soon as we decrease the patient, the level of support, the patient is reacting to this decrease in the level of support, and he he tries or she tries to increase the work of breathing by increasing, for example, here the PO1. So PO1, once again, is a useful tool that allows us to understand when we titrate the pressure support, how much work of breathing we are imposing on our patient. And for example, see here how dramatically is the difference between the patients who are able to sustain this decrease in the level of assistance and patients who fail, who are unable to sustain this decrease in the assistance. They try to work harder. And as a consequence, as I said, the respiratory rate goes up and the tidal volume goes down. Once again, breathing for our patient can be a large workload. If you take a look at the physiology books, it is written there that the amount of oxygen that we use for breathing is about 5% of our total oxygen consumption, which I'm sure it's likely the case in an healthy subject sitting, resting. But look at what happens with our patients. When we start from an optimal level of pressure support and we decrease the level of assistance, we see that the total oxygen consumption of the patient, this is the total VO2 of the patient, goes up from, let's say, 100% baseline to up to 150%. So the oxygen consumption can not double by increase by 1.5, just because we are reducing the level of support. Not only that, but even if we increase too much the level of support, what will cause to our patient is a dysynchrony with the ventilator. Our patient will start to fight the ventilator, and so once again, he will work more. Not necessarily an increase of the pressure support level leads to a decrease in the work of the patient. So basically, we have summarized some of these ideas in this review article on current opinion last year. And basically, we have tried to underline that spontaneous breathing and the breathing efforts, the pressure, the negative pressure that the patient is generating is not necessarily a good thing, it's not necessarily a bad thing, because it will have some positive aspects, but it will also have some potential risks for the patient. So it is important to monitor somehow the amount of breathing that the patient is doing. We know that esophageal pressure is the standard technique, and there is a talk on transpulmonary and esophageal pressure during this meeting. We also know, as you've heard yesterday from Antonio Pesenti, that there are other surrogate, easier methods to monitor the work of breathing of the patient, and we think that electrical activity of the diaphragm is a reliable and useful tool in this respect. So this was basically the conclusion of the first part. I did not step that much into the single parameters you can use, but I just wanted to underline what happens when you decrease the level of assistance and you ask more to the patient. And I hope I stressed the point that monitoring what the patient is doing is very important. Now, the second part is a little bit more detailed because it has to do with the timing of inspiration, of expiration of the patient and the ventilator. In an ideal situation, when the patient is trying to breathe, is trying to inspire, the ventilator should deliver an inspiratory flow, and at the same time, as soon as the patient wants to exhale, the ventilator should allow the patient to exhale. That would be the ideal situation, the ideal condition. However, we know that asynchrony occurs frequently. For those of you that are interested into this topic, I suggest you this reference. It's a concise review, so it's like 5 pages. It's very clear. There are so many references, very well written. Most of these things and much more are in there. So I suggest you to take a look at it. Patient ventilator asynchrony is not just an interesting physiological topic for those who, like me, are fascinated by mechanical ventilation. Patient ventilator asynchrony is a clinically relevant problem. This is just an example of a very nice, interesting article by the group of Brochard, by Arnaud Thiel, that shows that in patients who have an asynchrony index, and which is just one way to quantify the amount of asynchrony, but basically in patients with a higher incidence of asynchronies, the duration of mechanical ventilation is prolonged, and there is a higher incidence of tracheostomy, likely because of these increased duration of mechanical ventilation. Now here, clearly, we have a little bit of the chicken and the egg question, because of course, more severe patients with lower compliance are more likely to have asynchronies. But on the other hand, this paper does suggest that asynchrony per se can be associated to a risk of prolonged ventilation. And anything we can do to improve patient ventilator asynchrony is likely to improve our patient. Once again, I'm sorry if I am a bit schematic, but I would like to split the topic of asynchronies into two main conditions, once again, because otherwise I think it's a bit confusing. So first part is the asynchronies that occur during those ventilatory modes that are controlled or assist controlled. At our institution, we don't use much assist control modes, but I know it's very frequent, and I think it's perfectly fine using assist control modes as far as we are aware of what the potential risks are. So when we have a patient that is on volume assist control, pressure assist control, and is not sedated and paralyzed, he can breathe or she can breathe, and there might be risks of asynchronies. This is the first, maybe this is not exactly an asynchrony, but it's an example of, I think, a poor patient-ventilator interaction. You see here, this is the constant square flow waveform. This is what you would see in a volume assist control mode, and this is the pressure. Now, this is a fully controlled mode. The pressure is going up linearly. This is a breath when the patient is trying to inspire a greater flow rate than the ventilator is delivering. So here, basically, the ventilator, which is not allowed by our setting to deliver more than this flow, it's putting a brake to the patient. So the patient pulls with a negative pressure, and the ventilator has to decrease the pressure it's delivering to keep the flow constant. This is an example. It's a rather typical example you might see in patients on volume assist control. And this means that the patient is demanding more flow than the ventilator is delivering. Many of these examples I will show you today are something you get familiar to by looking at ventilator waveforms. So my suggestion is try always, maybe it's obvious suggestion, but still try always to look at the waveforms, and you might recognize similar patterns. The second issue that we might have with assist control modes with a constant inspiratory time and the patient triggering the ventilator is the fact that most of these modes have a set inspiratory times. Most of these modes, not all of them, have a set inspiratory time. And so the patient is able to breathe at a level of PEEP and at a high PEEP level or inspiratory pressure level. But in most cases, if the patient breathes here at the PEEP level, this will trigger a new inspiration from the ventilator. So inspiratory time is constant, expiratory time is short, and this is associated to the risk of breath stuck. And this is not totally demonstrated but it could be one of the mechanisms explaining the higher incidence of pneumothoraxes in Laurent Papazian's paper. Anyhow, anytime we have a patient who is on a on a mode which has a constant inspiratory time, we should be aware of the fact that if there is a spontaneous breathing going on, this will decrease the expiratory time and increase the IE ratio. The third form of asynchrony has just been described recently by, once again, the group of Laurent Brochard. And it's a very strange form of asynchrony. It's so-called reverse triggering. Here, this is volume control ventilation. You see square flow. The pressure goes up linearly, so it looks like everything is fine. And then, all of a sudden, we see that here the patient is inspiring. So in this case, it's not the patient triggering the ventilator, it's the other way around. The ventilator somehow moving the lungs and the chest of the patient is able to induce a diaphragm contraction. It's like if the diaphragm feels pushed and he wants to move away, and the diaphragm wants to move away. And as you see, they have described that patients have very constant pattern. In this case, it's a 1 to 2 entrainment rate, so every other mandatory breath, the patient is triggered to an inspiration. And with this phenomenon, if you change the respiratory rate on the ventilator, you will see the respiratory rate of the patient changing. Has this any effect? Yes, it does. First, because you see here that we are imposing an additional negative pressure around the lungs of our patient, and in some cases, if you see this trigger is very delayed, so the patient is able to trigger actually another breath, and there is some breath stacking, so that the total volume will increase. I thought this was an interesting curiosity, to be very honest with you, but once I was on call in the ICU, and on our own patient, this patient was on ECMO, we've seen this. We just have the NAVA catheter in just to, it's something we do quite routinely in our patients undergoing ECMO, and as you see, this is a clear reverse triggering. Here the ventilator starts on the yellow line, and much later the patient is activating the diaphragm to somehow move away. And here it's exactly the same. There is not the line, but if you pull a line down here, you see that the ventilator comes first, and then the patient comes. And this is something that honestly I always like, and looking at waveforms, I'm always there looking at waveforms. If we did not have the Eadi catheter in there, we would never ever have seen, because really you cannot tell. In volume control, somehow the activity of the patient changes the shape of the pressure. In pressure control, the only thing that happens is that the tidal volume will increase, so it's more difficult to recognize. And so, in the last 10 minutes, I would move to the last and maybe more tricky aspect of the asynchronies, which are the asynchronies occurring in those fully spontaneous assisted modes, which the pressure support is the most common, and also data show it is the most used. So I would basically refer to pressure support during my talk, but many of the things can be applicable also to like volume support or PPS, PAV, whatever. So first, inspiratory asynchronies, meaning the patient wants to breathe, but the ventilator is coming late. We have an asynchrony on inspiration. This oftentimes is caused by intrinsic PEEP. Intrinsic PEEP, as you've heard already, is a value of positive alveolar pressure, which is inside the alveoli, and it's higher than the pressure which is in the ventilator. And this is oftentimes due to obstruction and flow limitation. But for any reason, you have a higher alveolar pressure at the end of expiration than you have in the ventilator. Now I'm this patient, and now I want to start to breathe. if I start to pull with my muscles, everything I obtain, now I generated 5 centimeters of water of pressure, and the only thing I achieved is that I decreased alveolar pressure. But because the alveolar pressure is higher than the pressure in the ventilator, the flow will never, ever move from the ventilator to the alveolus. I will not be able to trigger the ventilator. I have to pull farther to make an additional effort to overcome this intrinsic PEEP. I have to bring my alveolar pressure below 0, in this case, below the PEEP applied on the ventilator, and only at this stage I will start to have a positive flow from the ventilator, and I will be able to trigger the ventilator. This is sequentially in time. This is a very super famous example of what I've shown you. This is esophageal pressure. This is flow. You see that here the patient starts to breathe, starts to create a negative pressure, but until the diaphragm generates 6.3 centimeters of water of pressure, there is no flow. And this is totally wasted pressure because it only serves to create a negative pressure inside the alveoli. So the best way to monitor the presence of intrinsic PEEP during assisted spontaneous breathing is by esophageal pressure. And we recognize it because there is a delay in time and in pressure between this drop and the moment the flow comes to the patient. Is this important in our patients? Yes, it is. Look at this paper, once again by Thiel. It's not the same one, it's later on. Look at what happens here. Here the patient begins to breathe. Okay, now I want to breathe, and the patient is generating 5 centimeters of water of pressure before the ventilator starts to deliver flow. You might think 5 centimeters of water of pressure is not a lot, but think this 30 times a minute. Even worse, what happens is that if here the pressure, the intrinsic PEEP is so high, the patient is not able to overcome it, we would have just a bump here in the flow. All the patient is able to do is create a bump here in the flow, a bump in the airway pressure, but there is no triggering of the ventilator. This is a wasted effort. So the patient tries to trigger the ventilator, but this effort is wasted. How do we, and once again, I said esophageal pressure is a very nice tool, but sometimes, even by looking at waveforms, we would realize that there are these bumps in the flow every other breath, almost. So looking at waveforms is really important. How do we treat these issues? These are our own data. You see, once again, bumps in the flow, likely indicating the presence of intrinsic PEEP. What is a possible solution to that? One possible solution sometimes is try to decrease the level of support, because this will decrease the tidal volume, and hence the patient will have a better, a shorter expiration. And you see here how apparently moving from this condition to this condition, the respiratory rate seems to have doubled, but in fact the respiratory rate of the patient has not changed, because this was the real respiratory rate of the patient, 1, 2, 3, 4, 5, 6, but we only see 3. And so in this condition, the respiratory rate of the patient did not really change. We are just triggering every breath. And quickly, this is not just an example, it has been shown that decreasing the level of pressure support, we might argue that 20 centimeters of water is a very high level of pressure support, which of course is the case, but conceptually, decreasing the pressure support is likely to improve patient ventilator synchrony. Another option is to use an external PEEP to ameliorate patient ventilator synchrony. Same patients as before, 6 centimeters of water, intrinsic PEEP. The patient here, though, has an external PEEP set on a very good doctor at 5 centimeters of water. what happens is that as soon as the patient generates a negative pressure, already there is a pressure gradient between the alveolus and the ventilator, and so the flow begins immediately. This is not our invention. Of course, it was clearly described. For my convenience, I brought you this figure. Here on the x-axis is extrinsic PEEP, and you'll see that intrinsic PEEP drops as soon as we increase the PEEP set on the ventilator. Actually, the idea of this work was not to replicate this finding, which is very well known, but was to show that similarly to what we do with intrinsic PEEP on esophageal pressure, we can use EDI, so that this level of intrinsic EDI, auto EDI, if you will, is a good indicator of the presence of intrinsic PEEP. If we see something like this, we have to think that the patient generates some EDI before there is an actual flow rate. And there is a very tight correlation between the intrinsic PEEP measured by esophageal pressure and the EDI measured by our system. And finally, the asynchronies during expiration, which are potentially as relevant as those during inspiration. How does, and this is a little bit more specific with pressure support, but still, I think pressure support is very widely used, so I hope you will find this useful in your clinical practice. How does the pressure support decides, the ventilator during pressure support decides that the inspiration has finished? You don't set an inspiratory time. You don't set, so the criterion is based on the flow shape and the drop of the flow. The ventilator looks at the peak in the inspiratory flow, and then the flow will decrease because of many reasons. And when you get to a given level, a given threshold, in this case 25%, the ventilator says, okay, this is it for inspiration. I'll allow my patient to expire. This level in most of the ventilators can be set. Here we set it to 10%, so you see the inspiration lasts longer. Here we set it to 50%, so we reach this value earlier, and the inspiration is shorter. So here we have an example of a patient with a very low compliance of the respiratory system. And you see, again, we see a bump in the expiratory flow. This occurs earlier than the one I've shown you before. Oh, sorry. Blue line on blue background is not a great idea, but here you might see that there is the muscle pressure of the patient. And you see that here the ventilator is cycling to expiration too early, because here the patient has just peaked his PMOSC, and then the ventilator, because the compliance is so low, the flow drops quickly, the ventilator says, okay, this is it. You're going to expire now. And so the patient is trying to pull the air inside, the ventilator opens the expiratory valve, and all the gas goes away. So this is early cycling during expiration, and it's something that typically occurs. Sometimes the patient is so strong that he says, no, I want to breathe now. And so the patient is able to trigger the ventilator again. You see here, this is a double cycling, which is oftentimes due to the fact that the patient is trying to pull the air while the ventilator has gone to expiration. How do we treat this? We just have to change the peak in the cycling criterion for pressure support. For restrictive patients, we use lower values so that expiration occurs later. For obstructive patients, we want their inspiratory time to be short, so we use a higher value here. going to my conclusion, it's very important to take care of patient-ventilator interaction during the setting of assisted ventilation. It's very important already to look at pressure and flow waveforms, but I think that nowadays we have more and more availability of esophageal pressure, Eadi, and other tools will come in the future, and we should really look at what the patient is doing, not just what the ventilator is doing. Sorry if it took 1 minute longer, and thank you very much for your attention.